Hello, and thank you all for joining us at the Bipartisan Policy Center's event, Opioid Crisis in Focus, Election Year Insights and Solutions. I'm Michelle Gazda, the Associate Director for BPC's Health Program. Today, we will discuss the opioid epidemic as we approach the 2024 election. Our expert panel will share insights from a recent national survey on Americans' views regarding the crisis, and we will discuss the government's response to the ongoing challenges. We will also explore key strategies for combating the epidemic moving forward. Before we begin, I want to thank the Foundation for Opioid Response Efforts for their support. At BPC, we are deeply engaged in behavioral health work, focusing on mental health access, substance use prevention and treatment, workforce challenges, licensure, integrated care, and telehealth. We are also actively working with our Youth Mental Health and Substance Use Task Force. I encourage you all to explore our recent issue brief focusing on safe and secure social media, and stay tuned for more resources from the task force. Now, I'd like to introduce Dr. Karen Scott, who will provide opening remarks. Dr. Scott is the president of the Foundation for Opioid Response Efforts and is a board-certified preventive medicine physician with over 20 years of experience in healthcare policy, quality improvement, and public health. She has held senior leadership roles at the Commonwealth Fund, New York City Health and Hospitals, New York Presbyterian Hospital, and the U.S. Department of Health and Human Services, focusing on health equity, patient safety, and system-wide care redesign.
Thank you so much, Michelle. And thanks to all of you for being with us today, both here in person and online. FORE has been pleased to partner with BPC over the past 3.5 years to support federal policy work on the opioid and overdose crisis. I wanted to just share a little bit about the foundation before we go on. The Foundation for Opioid Response Efforts, or FORE, was launched late in 2018 as a national health philanthropy to focus on the public health crisis of the opioid and overdose crisis. Our focus is on inspiring and accelerating actions and solutions to end this crisis, and to do that by convening and supporting partners advancing patient-centered, evidence-based solutions to the crisis. We focus on supporting work across 4 major pillars of professional education, payer and provider strategies, policy initiatives, and improving and increasing public awareness. I'm very proud to say that since we awarded our first grants in March of 2020, we are now at 107 grants awarded, committing over $43 million to these efforts to accelerating solutions around the country. And we, as a national foundation, really focus on making sure we are reaching different kinds of organizations and different communities across the entire country. Our grant programs include a significant focus on improving access to treatment for very high-risk and vulnerable populations, those at highest risk of mortality, supporting family and community-based prevention initiatives. We have an innovation program that focuses currently on improving timely and actionable data to address the crisis, as well as innovative ways of addressing stigma, particularly among health professionals who are charged with helping to support and take care of people with opioid use disorder. And last year, we launched our newest program, which was a focus on building capacity among smaller community-based organizations, particularly including recovery community organizations in smaller counties. So national data tells us that opioid use disorder and overdose deaths remain a major public health crisis and a leading cause of death in this country. And while the most recent data from about a week ago shows a very hopeful first significant reduction in overdose deaths, we have to remain mindful, of course, that that reduction is from an all-time historic high of over 110,000 deaths in a year and down to now maybe about 100,000. That is still way higher than it was before the COVID pandemic, and certainly much more higher than we can accept. The data also shows us that this continues to be an issue that impacts all parts of the country and all types of communities, though we are seeing some significant variations. And we know that in the most recent years, people in communities of color, particularly Black and Indigenous communities, are now dying at an even higher rate. As with many public health issues, success usually lies in bringing together many different strategies at once. It's having good data that's timely, it's having access to treatment and supportive services, and it's employing evidence-based prevention strategies. And so as a foundation, we try to think about how we can support some work at all of those different, across all of those different strategies. And it also means that federal leadership and policy leadership at a federal level is really critical to make sure that these types of strategies can be brought together in a concerted way and employed across the breadth of the country. This is really the only way that we're going to get to a point that this hopeful initial decline in deaths can really be accelerated over the next very short 2, 3, 4 years. And at the same time that we provide the supports that many families, friends, and communities who have been impacted in some way by overdose deaths over the past 20 to 30 years can really help to rebuild their lives and communities and move forward. So I'm very excited to hear the survey results and the discussion that's going to follow this morning. And I thank Anand, Julia, Michelle, and BPC for working with us on this project. Thank you.
Thank you, Dr. Scott. Okay, I'm excited to share findings from our recent national survey conducted by Morning Consult, which explores Americans' views on the opioid crisis as we head into the 2024 election. This survey captures voters' concerns, priorities, and policy preferences regarding the opioid epidemic, a central public health issue. This feedback will help us shape bipartisan solutions that address opioid addiction and overdose prevention effectively. The survey was conducted online from August 20th to August 22nd, 2024, so very recent, and sampled 2,202 adults, ensuring representation of the broader U.S. population. While there are many interesting findings, I want to highlight 5 key points that stand out as we approach the election. First, when we asked respondents how serious they believe the opioid crisis is, about 75% of people said it's a major problem in the U.S. However, we observed notable generational differences. For instance, 57% of Gen Z respondents considered the opioid epidemic a major issue, while 86% of baby boomers, viewed it as a critical concern. This gap indicates that different generations approach this issue with varying levels of urgency. Second, we also asked whether the opioid crisis is getting enough attention leading up to the 2024 election. Here we found consensus across political lines. 51% of respondents said the opioid epidemic and overdose crisis are not receiving sufficient attention in this election cycle. Only about 20% of Americans felt the issue was adequately addressed. This sentiment is shared by both Democrats and Republicans, with around half of each group agreeing that the opioid epidemic deserves more focus in the election conversation. Third, we explored strategies Americans support to tackle opioid use disorder. Respondents indicated that perceived level of importance for each strategy ranging from very important to not important at all. Overall, there was strong support for a comprehensive approach, from prevention programs to treatment methods to recovery services and to harm reduction strategies. However, it's noteworthy that fewer respondents recognized the importance of medications for opioid use disorder, a key evidence-based treatment option. As you can see here, and we did split it up by the different options, only 56% of respondents, the fewest of all treatment options, see MOUD as very important. Let that sink in. political differences emerged regarding border control as a strategy to prevent substance use disorder and overdoses. 74% of Republicans viewed border control as a top prevention strategy compared to 56% of Democrats and 54% of independents. This highlights how opinions on the crisis can diverge across party lines. We also wanted to explore public sentiment around harm reduction strategies, such as providing access to overdose reversing medications like naloxone and offering overdose education. About 80% of Americans agree that these harm reduction strategies are a vital tool in addressing the crisis. This widespread support indicates a recognition of the importance of saving lives in real time while still working on long-term prevention, treatment, and recovery. However, you'll notice some differences in the different strategies here. Fourth, when it comes to federal investments, more than half of respondents said the government should allocate more funds to address the opioid crisis and overdose deaths. This sentiment spans the political spectrum, with 61% of Democrats and 50% of Republicans and 46% of independents agreeing on the need for increased resources. Finally, when we asked Americans where they would prioritize taxpayer dollars, two areas stood out: preventing illicit drugs from entering the U.S. and improving access to quality treatment options. These priorities were viewed as the most important investments the federal government can make to combat the opioid epidemic. The emphasis on prevention and improved treatment reflects the public's desire for both immediate and long-term solutions. These findings underscore that Americans recognize the opioid crisis is a pressing issue that demands immediate attention, particularly as we approach the 2024 election. The strong support for a comprehensive bipartisan response centered on prevention, treatment, recovery, and harm reduction highlights the urgency of collaborative action to combat the epidemic and save lives. Some of you those in the room got a copy of our survey. We've also published a detailed summary of these survey findings on our website. You'll be able to access those results at bipartisanpolicy.org. Now, it is my pleasure to introduce Dr. Anand Parekh, BPC's Chief Medical Advisor, who will lead our next conversation.
Well, thank you so much, Michelle, and it's so great to see everybody here. As Michelle mentioned, I'm Anand Parekh. I'm our Chief Medical Advisor here at the Bipartisan Policy Center, and I'd like to call two colleagues up to the stage first as we start our fireside chat. The first is Regina LaBelle. Regina is the former acting director of the White House Office of National Drug Control Policy during the Biden administration. Regina is also professor and director of the Masters of Science in Addiction Policy and Practice program at Georgetown University. Regina, thank you for being here. And also, I'd like to ask Jim Carroll, former director also of the White House Office of National Drug Control Policy during the Trump administration, as well as a member of BPC's Youth Mental Health and Substance Use Task Force, to join us as well. Jim, thank you for being here as well.
I got the instructions wrong, as always.
Two former drug czars, terrific public servants, as well as thought leaders. Before we start, I do want to just recognize Michelle and the entire BPC team who has been working on this issue for quite a long time, and also recognize, again, Dr. Kieran Scott, as well as and the Foundation for Opioid Response Efforts for their tremendous leadership over the last several years. It's been a great partnership, and really happy to put on this program. So, Regina and Jim, we have about 20 minutes, and Michelle, thank you for those top-line comments on the survey. A lot to unpack here, but I think the first question, just cutting right to the chase, is you've reviewed the survey data, heard the top lines. Is there something that's sort of a takeaway, the most important takeaway from your perspective And maybe a second question, is there anything that surprised you from that survey data? And Regina, if you want to start first.
Sure. Thanks, Anna, and thanks Bipartisan Policy Center and FORE for having this important discussion. We're all awaiting the election, and we're going to talk more about this, how this issue and how it affects election debates as well. In looking at the survey, I think one of the things that I was kind of pleasantly surprised to see is that there is a consensus about evidence-based treatment, about the importance of evidence-based treatment, and an understanding of how prevention can help decrease overdose deaths and substance use disorder. I think I was a little bit surprised to see that there have been there's a growing attention or acknowledgement that criminal justice first policies don't work, and also that prevention is more than just say no. That there is, science and evidence behind it. There's a way to do it, and there's a way not to do it. So I think, number one was just the consensus that I think we can build on, and a bipartisan consensus that we can build on. And then secondly, that we're learning from the past and hopefully not repeating some of those mistakes.
Great. Thank you, Regina. Jim.
First off, Alan, thank you, and thank the Bipartisan Policy Center. It's always an honor to be with Regina, and I think you'll find that there was really not substantial differences in the way we approach this issue. For me, the takeaway was, and one of maybe the most surprising was the difference between urban, suburban, and rural communities. And what the survey shows was that suburban and rural communities showed that this being a very important issue, while urban communities said that this is an important issue, a little bit less. For me, the takeaway is that suburban and rural communities are finally waking up and realizing that this is an entire countrywide problem, regardless of any demographic that you want to associate with it. And so it's finally sort of coming to terms that this really is a crisis that impacts all Americans. And so that was one of the ones that I was really distressed, but also somewhat pleased to see that everyone sort of understands that this is a real problem for themselves, for their loved ones, their family members, coworkers. And so, that part was a little surprising, but happy news to see that everyone is waking up.
And we have seen, correct me if I'm wrong, in recent years, also an uptick of overdose deaths in urban areas, right? This is not just a rural and suburban issue as well. Geographically, it's not just a Northeast and Midwest, seeing high overdose rates in the West. I don't know if you want to talk a little bit about just the changing picture of the opioid epidemic today compared to what it was even just a couple of years ago, polysubstance, and your point, Jim, if you, affecting everybody. Regina, any thoughts there?
Yeah, I mean, Dr. Scott talked about the 10% decrease in overdose deaths, so good news. But you need to dig deeper and lift the hood on what those numbers really mean. And we're doing a little bit of work on this. I'm a lawyer, not a data scientist, so we have some data scientists at Georgetown who are helping us look at this. But Washington, D.C. is a perfect example of a place in America in the top 5 overdose death rates in the country. Wards 5, 7, and 8, Black men who are 55 years old. And that's not unique to DC. It's also happening in Baltimore. There's been a New York Times article on that. And in some states, it's great news that we're seeing overdose deaths, but it's important that we not look at this in totality, that we really dig deep into who are we leaving behind. And that's why looking solely at the mortality data isn't always the best metric. It's what we have, but it's not always the best metric to define success.
Yeah, you miss a lot. Yeah.
Yeah, I mean, I'm thrilled, like Regina, and I think everyone, working on this issue that we've seen a 10,000 reduction, but that's completely unacceptable. Dr. Scott said that, and that's the way we should look at this. And, this is a crisis, and the fact that we've made some improvements means that hopefully we're headed in the right direction. I think it's important, though, to also remember that some of these communities, especially communities of color, communities, and we were talking earlier with Chad Jackson, who runs the DC Opioid Abatement Commission, about there's not enough treatment for all genders, that most of the treatment centers are male-dominated for male-dominated patients, and there needs to be more access for everyone. The other thing, and I think this is important, you touched on it, that it is the #1 cause of death for 18 to 45-year-olds. And part of that is driven that it's, and when you talk to a lot of parents, and I'll speak from the heart because I talk to parents every day who have lost a child, is they really inappropriately so get upset at the word overdose. That these are truly, for a lot of these deaths, are accidental, that they don't understand what they're doing. And, I was raised in the 60s and 70s, and, there were a lot of things out there, but they weren't fatal. And you can make a lot of stupid mistakes. I made plenty. If you ask my wife, I probably still make a lot. But back then they weren't necessarily fatal, consequences. And so I think the idea of, we can't say abstinence only, but teaching people, about the dangers of what's actually out there in ways that they can hear it, in sensitive manners. And some of the training that, I got back in the 60s and really the 70s was downright awful. In fact, some of the studies that came back said that people who went through some of the, just say no type campaigns actually had a greater chance of experimenting, and I hate that word, with illicit substances than those who didn't go through. And so to Regina's point, culturally appropriate prevention training is key.
I want to just, for a second, play off, Jim, that point about not quite 18 to 45, but the Gen Zers in the data that we just saw, seeing this as less of a major issue than other age groups. So what do you make of that, particularly given a rise in youth overdose rates and amongst young adolescents as well?
Part of the problem, I think, is their very age. And for Gen Zers
Exactly
here, I was immortal as, at that age group, right? Nothing could, harm me. I could bounce off a car speeding down the road. I could pretty much do anything. And I had no chance of, winding up in a Lord of the Rings type scenario. And I think that's part of the issue, is that they don't understand. And again, it goes back to appropriate education, prevention, training, from peers about we're actually not, safe. I don't know, Regina, were you?
Yeah, I mean, as a parent of a Gen Zer, I think it's just the age. That's what I think. But maybe I'm sure the data scientists can look further into it to find some other, other underlying issue. But I do think in that age group, I would be curious to see if you ask them about alcohol use disorder, if you ask them about gambling disorder, what they'd say, because that is a growing problem, challenge, and mental health issues in that generation. So I think some of it is just that's who they are. Yeah. We love them. That's who they are.
Yeah. So given the survey results, what do you think the general public needs to understand better about this crisis? And are there some is there any misinformation that needs to be addressed, any misconceptions out there that really stand out looking at the results?
I mean, I think that we have come a long way since when we first started working on this issue. It was really like treatment was a washing machine. You go in and you come out and you're all good. That there is an acknowledgement of the important role the recovery plays, and also the data showed that a recognition of the role that housing, nutrition, the social determinants of health, that plays in both driving substance use disorder, but also driving recovery efforts. So I think that that's, those are some things that I took from that.
Great. Jim.
One thing that I was really, sort of happy to see on that front, and Regina used this term, Michelle used this term, and I think Dr. Scott said this too, is they didn't just say treatment, they said evidence-based treatment. And I think there's a greater recognition that not all treatment is the same. And that, Jason, I'm looking at you, right, with 60-some centers across the country, it's not, and I feel like I'm saying a lot of things, I hate this and I hate that. Another saying that I hate is, I know, right? oh, how many heads in beds do you have? As the father of our daughter is in recovery from a dependence to opioids, and Chad and I have talked about this, is heads in beds. I hate that. I want to throttle them. But the scary thing is 9 years ago, 10 years ago, whatever it was, 8 years ago, that we discovered our daughter had a problem. How did we find, treatment? It was Google. And you look online at the ads and which one looks good, and how do we find it? And so I think we're realizing now that evidence-based is critically important.
Yeah. How concerned were you both to see in the survey results that of the different treatment paradigms, medications for opioid use disorder ranked last when that is really the gold standard for treatment?
I think, I mean, I don't think people really understand what it means at this point, necessarily. I mean, we who are in the space spend a lot of time talking about medications for opioid use disorder, but it wasn't that long ago when the term swapping one addiction for another was used all the time. So I think, I'm not sanguine about how much work we have left, but it shows that we still have more work to do.
Yeah.
So, when I was director during the pandemic, we did an emergency lift of the X waiver.
Yeah.
And, now they've made that permanent under President Biden. And so I'm thrilled about that. I'm sure you must be happy about that as well. But when, I did it and worked with the DEA and HHS, and I know there are some SAMHSA folks here, to be able to lift the X waiver in an emergency basis, you'd be surprised how much pushback I got, not from ignorant people per se, but from people that were supposedly experts on this and talking about it. And there were books written about, we are just trading one addiction for the other. Oh, buprenorphine is being diverted, and you're making a huge mistake. I had one person contact me who ran a treatment center and said, huge catastrophic mistake, it's being diverted. And I said, well, is it being diverted for abuse or being diverted for people who don't otherwise have access to it?
Right.
And he goes, well, I don't know. And I'm like, I know it's being diverted for, good purposes, sadly not under a doctor's supervision. And so expanding this and changing that mindset, I think we've come a long way in 10 years. More to go.
Really important points. So, November coming up, should the candidates be talking more about this issue? You saw the survey results. I think it was 51% of the public thinks that this issue hasn't received enough attention. Should the candidates be talking more about this? And if so, what should they be talking about?
Regina, go ahead.
So,
is there an election in November?
How many days? 40, 41? Is it?
So I think it's good that people think that the campaigns should address the issue. I don't recall the exact question, but I think there are two things. First of all, it's incumbent upon all of us as citizens in the United States to be active and to talk to candidates about this issue. Because if they don't hear from individuals who've been affected, they don't think it's a problem. And so when they say that it should be brought up, I think that's where it comes up. Like, show up at local meetings, go to congressional hearings, those things. Make sure that people know that there is a movement of people. There are 23 million people in this country in recovery, and they vote. So let's do that first. The second thing, though, about it being on the national debate, campaigns are about contrast. I'm concerned that if it were brought up more on the national stage, it might not yield the best results. Remember when crack cocaine was a national debate? That was incredibly damaging legislation that came out from that. So having it be partisan and political is not always the answer.
My takeaway is, first off, the fact that candidates are either side are discussing it as much as they are. I'm happy. I was really not expecting this a year ago for either candidate, regardless of who it was going to be, to talk about this issue. And so the fact that it's being talked about as much as it is, again, I'm happy to see it. But I don't think there's anyone in this room, who feels that good, solid, conversation about it, to Regina's point, is happening enough. And I think we need to be careful about the conversation and understand the stigma that comes along with it, but also recognize, as we have for decades now, that this is a disease, that this is something that can be treated, and it's something that can impact anyone, regardless of the demographics. So I'm happy that it received as much attention as it did. There are people out there, though, that I don't like. Again, I think that's, if you're keeping track, I think this is the third group that I hate, is the people who say, that, oh, we're spending too much money on this. We saw that on the survey. I think, 5 or 6% of the people. I don't like those people. And I try to like everyone, but and I was often asked and testified, look, I was, in a Republican administration. I've served in 2 Republican administrations, and testified, are we spending enough money? No. And I remember being asked, well, what is the right amount? I'm like, okay, well, we're spending about 35, now a little closer to 40 billion. And it's like probably at least double, probably more along the lines of close to triple in terms of what we should be doing. And if you talk to these parents who have lost a child or who don't know where their child is, you can't put a price tag on them. And so I think the most fiscally conservative person in the room, we're not spending nearly enough time, attention, and compassion on this issue.
I don't see the timer. Michelle, Lauren, do we have? Oh, perfect.
I hate the timer. I think that's
Or
So we're going to take. They're going to take some questions after the second panel, but I do want to get one more question in. So irrespective of what happens in November, from your perspectives, what's the main opportunity for the next Congress, 119th Congress, as well as the next administration, to continue reducing overdose deaths in this country?
So I think there are 3 things, and one, I hope that it's resolved soon, before the next Congress, is the telehealth rule, telemedicine rule. It allows for virtual access to controlled substance prescribing. Why that's important is because not only for rural areas that might have treatment deserts, but it's also important for the population of people who are incarcerated and upon reentry who have the highest risk of overdose death. So that taking care of that telemedicine rule, making it permanent, extending it, that's number 1. Number 2 is making sure that the funding continues where possible, it's increased, but with Medicaid and Medicare. And then lastly, paying attention to alcohol use disorder. It kills over 170,000 people in the country every year. That's something that has to go along with any other type of addiction strategy.
Terrific. Yeah, Jim.
Again, this is where you all hate me, both of us. They're going to, because we really don't disagree on a lot. I mean, if you all were coming, as we talked about earlier, this being the 5 at 5, it really isn't. There really aren't partisan differences, too much in this space. I think going forward, I think what we'll see is increased funding from either side in terms of what's happening. I'm happy to see some of the announcements by President Biden, I guess now about 2 weeks ago, on some of the trade sanctions and stopping the flow and oversupply of drugs in this country. In the survey, it was 80-some% of the people realized that supply matters. And I used to get asked this question. I'm sure you got it, when you were the acting director as well. Do you focus, on supply, or do you, focus on demand? And you have to be able to walk and chew gum at the same time. And so I think that we'll continue regardless of who is sitting in 1600 Pennsylvania Avenue. And I think regardless of what happens in Congress, you're going to see some increased focus on spending money appropriately, expansion of Medicaid and Medicare, especially for people who are about to be released from incarceration to the general public, and keeping those and not cutting them off when they enter incarceration. An increased focus on reducing the supply, and hopefully more evidence-based prevention messaging as well, so that the immortal Gen Zers, understand what's out there.
But last question, I promise. Your old office has not been reauthorized. Should ONDCP be reauthorized?
Well, they voted it out of, they did have a markup last week. At the end of this 3-hour markup, they finally voted it out. So yes, it should be reauthorized.
All right.
Yeah, I'm not worried about it. It'll be real. And what I would love to see in the next term of either candidate is see the office elevated back to cabinet level again. I think the ability to sort of have greater convening authority and signify the importance of this to the general public would be important as well.
Well, we can go on for a long time, but please join me in thanking both Jim and Regina for their comments in public service. Thank you.
Thank you.
And at this time, I'd like to ask Ken Schatzkis, Program Director for FORE, Foundation for Opioid Response Efforts, to come up, and Ken will be introducing our second panel. Ken, thank you.
Fantastic. That was a fantastic panel. Thank you. As Anand was saying, I'm Dr. Ken Schatzkis of the Foundation for Opioid Response Efforts, and today we have 3 grantees that are going to help contextualize what we see in the survey results. So I'd like to introduce to the stage first Dr. Margaret Kuklinski. She is the Director of the Social Development Research Group and a social work endowed Associate Professor in Prevention at the University of Washington School of Social Work. She's helping to build the first of its kind technical assistance and training center to build the capacity within OTP's opioid treatment programs to deliver evidence-based, family-focused interventions designed to build nurturing, responsive, effective parenting skills that protect against substance misuse, emotional and behavioral problems in children. Thank you, Dr. Clancy. Second, I'd like to introduce Dr. Alistair Martin. Dr. Martin is an emergency medicine physician, an assistant professor at Harvard Medical School, and chief executive officer of A Healthier Democracy. Before the X waiver was removed in 2022, he led a national effort to encourage emergency clinicians to obtain these waivers, which resulted in over 5,000 clinicians obtaining their X waivers. Dr. Martin also served in the office of Vice President Kamala Harris at the White House, where he worked on opioid policy. And in 2003, he was invited back to celebrate the removal of the X waiver in recognition of his efforts to eliminate this barrier to accessing opioid addiction care. Thank you, Dr. Martin. Last but not least, I'd like to invite Jason Pritchard, who is Savita Health in Virginia's Director of Outreach, a certified peer recovery specialist, president of the board of the Substance Abuse and Addiction Recovery Alliance of Virginia, and a person in long-term recovery. During COVID-19, Jason helped develop a suite of virtual recovery services for Ballad Health to serve people coping with opioid use disorder in 29 Appalachian counties in Tennessee and Virginia. He also expanded access to these services and introduced these groups in the region's jails, strengthening the area's workforce by creating opportunities for people with lived experience of addiction, including those who are incarcerated, to work towards certification as peer recovery specialists. Thank you, Jason. So I just want to start, we all come to this work, from different experiences. And I just want to start with, allowing you to tell your story and how you came to this work. So, Dr. Kuklinski.
Okay, thank you, Ken. I appreciated the chance to reflect on what brought me into this field. And I come at this work as a clinical psychologist and also as someone with a background in economics. And that interest in the human side and the business side is a thread that goes through my work to this day. But my tie to prevention, my story for prevention, really began in 2010 when I first learned of the Social Development Research Group at the University of Washington. SDRG was founded by David Hawkins and Rico Catalano, who are committed to the idea that we needed to reduce the need for treatment and incarceration for young people. And to do that, we had to go upstream. We had to get at the root causes, the drivers of these outcomes, to reduce the need. So there were many influences, structural drivers, social drivers, but I want to highlight how important for them the idea of strong social connection was as a foundation for healthy development. They were early believers in the importance of connection, the importance of bonding, and I think over the last few years, we've heard more and more from many different spaces how important those ideas are. Social connection for them was not just something to hold up. They also wanted to show how preventive interventions could strengthen social bonds and social connection, and they developed strategies to do that. And one of the things that's most important in that work, from my perspective, is that while we want those social bonds to be in the family, We really hope that they will. We want people to be nurtured in the family. They also can come from other places in the community, teachers, coaches, peer groups. There are lots of sources for positive connection, and they worked on interventions that develop those sources and shown that they lead to better outcomes. And I want to say that that strategy really spoke to me personally. Like many in this room, addiction and mental health issues were part of issues in my family growing up. And I know firsthand how important those meaningful connections from various places are to getting to healthy outcomes. So I wanted to be a part of that. And that's really what led me into the field of
Thank
prevention.
you. Excellent. Dr. Martin?
Thank you, Ken, and thank you to the BPC and to FORE for convening us. My story of how I got involved in this work starts one night back in 2015. I was an intern at Mass General Hospital, and I had hair back then. And I was taking care of this young woman at 11 o'clock on a Friday night, and she'd come to me with this story. She said, "Doc, about 6 weeks ago, I'd fallen down the stairs at my son's daycare, and she had this massive ankle fracture, had a big surgery at another hospital, and this other hospital put her on opioids." And she tells me, she says, "You know, I had felt okay for the first week, but something strange happened. When I stopped taking the medication, I just didn't feel normal, didn't feel right." So she started taking some extra medications that her husband had in the kitchen cupboards. She ran through those, eventually ended up getting medications from a dealer in her hometown where she grew up in Massachusetts. And that night she had made this decision. She said, "Absolutely not, I'm not doing this. I didn't sign up for this." So she texted the dealer and she says to this dealer, "Lose my number." The dealer says, "No problem." And she actually showed me the text message. Says, "No problem, good luck." About an hour later, she hears a knock at her door, and it's her dealer. And her dealer says to her, "I know what you said, but you know, recovery is hard. So I want to give you a couple of pills for the road." And he gave her 6 tiny oxycodone tablets for free on the house. Her husband saw this and intervened and brought her to the hospital. They were looking, as we heard earlier, online, Googling. They couldn't find anywhere else to go, so they came to the emergency department. And they meet me, little intern, and tell me this story. And what do I say to this patient? Of course we're going to help you. We're at Mass General Hospital. I go back to my attending and I say, "Look, we've got this young woman, want to get her help, want to admit her to the hospital and get her on her road to recovery." And the attending doctor says, "That's not what we do here. Discharge her." And that for me was really, first of all, it was the longest walk I've ever taken in my life, from that attending's desk back to that patient, to tell that patient, "No, I'm sorry, we're not going to help you." But for me, it really set me off on this journey. And how can we turn emergency departments into the front door for addiction treatment? And the work of Get Wavered, which we'll talk about a little bit more, really was inspired by her story. I don't know if she ever got the treatment that she needed, but everything I do now in this space, I have her in my mind and my heart.
That's a story we hear very often. Yeah. Jason.
Yes. So I'm Jason Pritchard, and my story is a little bit different. So I grew up very poor, and one thing from this story I want to be a takeaway is that poverty drives trauma, and trauma drives addiction. And so I grew up really poor. Drug use prevalence was very high within the family, and in maybe 99, 2000, I got in a really bad car wreck. 2 of them actually within a couple of months of each other, and I had to have reconstructive knuckle surgery, broken wrists, 3 broken ribs, and knee surgery. And that was like right when Oxycontin was taken off. So I got prescribed 60 milligrams of Oxycontin a day, 6 milligrams of Klonopin, and 750 milligrams of an antidepressant. And I was on that medication for probably 2 or 3 years, had to have a few follow-up surgeries. And I moved from North Carolina to Virginia, and the doctors in Virginia said that I was over-medicated, and so they sent me to UVA Pain Management, and UVA Pain Management said, You're not over-medicated, you're incorrectly medicated. And so they sent me back to Southwest Virginia with a prescription for 80 milligrams of methadone a day. That turned into an even bigger nightmare because none of the pharmacies wanted to fill the methadone prescription. So the doctors there at UVA, they helped through some papers and threats. They got the medication filled, and so, but I'll back up. When I started taking the 60 milligrams of Oxycontin, that really advanced me into a 16-year journey into addiction. So I spent 16 years in active addiction. In 2005 or 2003, I did start the methadone. While on that, I graduated from Virginia Tech. And, you know, the average of reoccurrences in a person's life is 7. So I consider that to be my first attempt at recovery. But there would be falls along the way. And in 2012, in 2010, I had got in another car accident. And again, right back on the pain medications. I had to have a knee surgery again. And that led me into encounters with law enforcement. So in 2012, I received a 6-year prison sentence. And I went to jail on March 20th of 2012 and came home March 20th of 2017. I knew I didn't want to go back to prison. So I started working while incarcerated. I started attending all the reentry fairs, and I'm pretty good at keeping track of everything that I encounter. I'm an auditory learner, so if I talk to you and you tell me something, I have a pretty good way to recall it. But I just started writing down people's numbers. Came home, got involved with 3 things that I'm going to talk about that was very big in my recovery, which was community. You know, I had to have a recovery community. I had to have purpose, so I had to have employment, and my faith. So those 3 things really helped me move along. And today, you know, I sit here before you, I really like to have the pictures. I have my incarcerated picture, and then I have my picture the day that they promoted me to Director of Outreach for the state of Virginia for Savita Health. And one thing I challenge people is that in every person that's been incarcerated also sits the person that's before you today. And us as the people who are writing the policies and doing the treatment, the real challenge is finding this person in front of out of that person and how to bring that out.
It's incredibly powerful. Thank you, Jason, for sharing your story. So I think you can see here we have the whole continuum of what we think we need to be doing around addiction care. So we have expert in prevention, treatment, and lived experience in recovery. So I want to start with prevention, and specifically around the survey results that we see around Gen Z. You know, Gen Z doesn't see the opioid crisis as much of a problem as older generations. We know that substance use is down amongst youth, but overdoses are rising. So, Margaret, can you talk a little bit about what is driving this increase in these patterns and what's your perceptions of youth at the moment?
Sure. And I think you'll hear me echo some of the themes raised earlier. I think the place to begin with those data is that Gen Zers are between the ages of 12 and 27. So in this age group, it's true, we've had some successes. Alcohol use is down, cigarette use is really down. Vaping, cannabis or marijuana use, opioid use, those things are not down. So overall trends are better, but what we also see in this age range is a 4-fold increase in mortality related to opioid overdose in the last 20 years. And in ages 12 to 17, a 30% increase in mortality in the last 3 years. So some of those trends that we're seeing reflect these tragic trends that we've been experiencing for too long now. When I look at those data, I actually see that 57% of people in that age group do think this is a problem. That's more than half. I think that's actually a sign that this is recognized to be a problem in this age group. I think the other part of those data is that people who are 27, they're just beginning at a population level to really come down in their substance use in general developmentally. So for them to not necessarily experience this as big a problem as older groups, I think it's not surprising. I also think as we go through life, we sadly know more people who've been touched by opioid misuse and mortality. And so it's not a surprise that the numbers expressing concern, the prevalence goes up.
Thank you.
So that's how I see that.
Thank you. And Dr. Martin, moving to how we help people in the throes of addiction and treatment. End of 2022, the X waiver was removed, and we expected that there was going to be an increase in people being able to access treatment. We did not really see that. Still, only 18% of Americans who could use this treatment have access to it. So, I'm curious, as a practicing physician that sees this every day, what are the current gaps in treatment access, and what role can policymakers play in facilitating it?
Yeah, so to pick up the story after that night, after taking care of that patient, I was naive, Ken. I diagnosed the problem as the fact that ER physicians in my department didn't have a DAX waiver. And if we could just solve that problem and get more physicians waivered, we'd have more folks who could prescribe buprenorphine. And so the work we did with Get Waivered first started in our department at Mass General Hospital. We went from 1 waivered physician to 47 out of 50. We then took that show on the road and got 5,000 emergency clinicians all across the country this waiver. But the numbers didn't increase, right? There was this sort of slight uptick. And so the reality is the picture is much more complicated. And so I think that the 3 levers that I would suggest policymakers take a look at to really put forward this multimodal approach is, number 1, we heard from Regina, extending the telehealth provisions, right? The idea that on December 31st, 2024, this year, those telehealth provisions are going to go away, and we won't be able to help folks get access to buprenorphine and other types of treatment via telehealth. That's going to absolutely not continue this trend that we're seeing in the data. The second thing I'd say is the Affordable Connectivity Program is a little-known law that most folks may have heard rumblings of a couple years back, but it's a $14.2 billion law that gives patients either $30 or $75 a month to pay their internet bill or their phone bill. So we think about telehealth. Well, we still live in a country where some 20% of the population doesn't have access to high-speed internet. That bill, that law, sunset in May of 2024. And so we need to reauthorize that bill. The third thing I would say is that right now there is a very special and I would say cool provision that allows emergency physicians like me, or internal medicine docs, or pediatricians, to become addiction specialists. It's called the Practice Pathway. American Board of Preventive Medicine allows folks who are trained in some other field to take the test to become an addiction doc, and they can become addiction specialists. Well, that's going to end December 31st, 2025. So I think there are a couple of different things that we can do. Some of them have closing time windows, and the time to act is now.
Oh, wow. So, moving to recovery, Jason, people can get the treatment. You spoke about how it can be nonlinear. People can relapse. And it can mean many things to many people. So from your own lived experience, I was wondering if you can, share what the supports, what you have found, has helped the people that you have helped need to sustain their recovery.
So can I take 10 seconds? And
Sure.
just add something to what he
Absolutely.
said? So I will say that removing the X waiver was fantastic, but as he was saying that the numbers, it didn't really give the outcomes that we thought. Well, what it did is it peeled back a layer, and what we found is that the X waiver, it was removed, but what happened was local community politicians, I guess you would say, started changing their town charters, and so they installed this thing called a special use permit, And so you have to go get a special use permit in some of these towns, and that gives the town council the opportunity to deny you. And so removing the X waiver removed like the problem we see on the surface, but when we opened it up, there's many more problems that's going to have to be addressed on the local community level. Now, for recovery, I said before, 3 things that were very important to me was purpose, second chance employment, like we've got to do a lot with second chance employment. Community connection is the opposite of addiction. And so just having community spaces, safe spaces, respite spaces for people to be able to interact with other people in recovery. And then for me, faith was a huge thing. So having Tennessee does a fantastic job with recovery-friendly congregations where they know they're not going to come and be further stigmatized. But down under that, you have to address the social determinants of health. So if we do not have the basic needs, food, housing, clothing, then a job and purpose is not really going to move the needle. But if we do have food, housing, and clothing, and a person can find their purpose, you will see the needle start moving.
Oh, absolutely. Social determinants of health is incredibly important. And we talk at FORE quite a bit how what we see in recovery and prevention, the tenets of it, they're not that different. So, Margaret, I'm wondering if you can talk a little bit about, prevention can take on different meanings for various audiences. I think the survey results, looked at prevention from a border control kind of way. But can you describe, other ways of thinking about
Sure.
prevention and how the work that you do?
Sure, and I really appreciate the chance for us to think about the different ways that we can prevent these problems. And preventing supply is one crucial part. If you look on the HHS website, the overall opioid prevention strategy has 4 buckets: primary prevention, harm reduction, treatment, and recovery. And each of them is really important. I think often when we talk about opioid prevention, we're referring in shorthand to overdose prevention and to the use of naloxone to prevent death when people most need it. So really critical. But another type of prevention is this primary prevention angle. And the goal there is to keep folks from ever getting to the point of addiction, from ever needing that naloxone, from ever needing treatment. And the strategies used are often far removed from substance use itself. They are about building strengths, reducing trauma, building those support networks in the community, those connections that are so important along each step in the continuum. So when we talk about primary prevention, that's what we're referring to as distinct from overdose prevention, supply side prevention, and this overall prevention strategy. I hope that's helpful.
Oh, thank you so much. Alistair, we heard a little bit about, this historic, unprecedented reduction in overdoses last week. Brian Mann of NPR published a story that there may be at least a 15% decline in fatal overdoses. But even with this decline, overdoses in Black, Brown, and tribal communities, are still climbing nationally. So can you speak about, strategies to reach these communities and how we could be able to help them access the treatment that they need?
Yeah, no, I think it's really important that we drill down into the data and get a sense for what is happening and to whom is it happening, right? Is this recovery that we're seeing unevenly distributed? I'll highlight some data that came out of T.H. Chan, the Harvard Chan School just last year, which demonstrated that African Americans are offered things like buprenorphine nearly 77% less often, right, than white patients who come in with addiction, right? So I think part of this is you can see in the data that some of these strategies are working, but I think some of our old biases are getting in the way and disrupting, the end result in terms of who's getting access to those treatments. But I want to pick up on this theme of the social determinants of health.
Absolutely.
Right? Because look, in my emergency department, how good is it for me to get a patient started on medication for addiction treatment if I'm discharging them to 4 degrees outside in Boston and it's freezing and they have nowhere else to go? How good is it for me to rewrite their buprenorphine prescription if they're starving and they don't know where their next meal is going to be? How good is it for me to check their methadone dose if they don't have transportation to get to their OTP, to their methadone clinic? And of course, we are going to do all of those things in the emergency department, make sure that their medications are there for them and their treatments are available. But until we have serious discussions and policies that are addressing at the social determinants of health at that level, I think we're going to see a much harder and more difficult conversion to success in some populations.
And I think that segues right into a question I have for Jason. These social determinants of health, these recovery services that are crucial, they're severely underfunded, and compared to treatment. So, in your own experience, what would you say to policymakers and communities to ensure that these essential services are available?
Yeah, just reiterate what he says. You can get a person stabilized in inpatient or outpatient services, but if we're not dealing with the social determinants of health, it's not addressing, basically what I like to say, it's not addressing the underlying cause of the addiction. So if the person's not having their basic needs met, they're not going to attend counseling, they're going to be sporadic in their substance treatment. Occasionally you'll get them to go inpatient, and a lot of times that'll be because they can't find anywhere else to live or to be housed. So they just take inpatient as an option to be warm and dry for 30 days. But I think we really have to start looking at the baseline, the basic needs in order to really move the needle.
All right. So I want to get two more questions in. So harm reduction was in the survey, and it's a little bit of a political football. And so I wanted to, give you all an opportunity across the continuum of prevention, treatment, and recovery of what does harm reduction mean to prevention, to treatment, to recovery. So,
Sure. Our work focuses on young people primarily. And I think we'd all agree that our first choice outcome for young people is that they don't use drugs. But that's not realistic. People do use drugs. And I think that harm reduction becomes a really important concept at that point. What we want for young people in that case is that they don't escalate in their use, and that doesn't become addiction or very harmful, chaotic, sporadic use. So harm reduction, I think, takes on that meaning in the field of prevention, really important counterpart to primary prevention.
Alistair?
Yeah, I think that emergency departments can and should be the front door for accessing not just treatment, but harm reduction techniques. And so I think what we can be doing as emergency department clinicians is making sure that we are prescribing naloxone, giving patients take-home naloxone. Number two, making it easy for patients to get into medication for addiction treatment. For instance, at our hospital, we have folks get a take-home buprenorphine dose. That means they don't get a prescription. They literally leave the ER with 5 days of medication in hand. And then the last thing is having a tight follow-up, closed-loop referral to outpatient addiction treatment to continue getting folks the care they need once they leave the ER.
Right. Jason?
And I would say harm reduction would be just meeting a person where they are and meeting the needs that they have in that moment. And that's going to require us taking our personal biases and putting them on the shelf and just meeting the person where they are and meet their needs. Their needs right then may not be recovery. It may be food, or it may be clean use devices, but whatever it is in that moment, that is harm reduction.
Great. So we have a minute and a half left, so 30 seconds apiece. But what is your final message that you want to convey to policymakers and Americans, on this issue as they head to the polls in November?
So my message is that all of the spaces that we're representing on this stage are important parts of the solution to the opioid crisis. What I would say about prevention, what I think makes it fit a unique space, is that it's the strategy that really aims to lower incidence. So if we want to turn that spigot down on the need for treatment and recovery, we want to make sure that prevention is well supported and able to be used by agencies and strategies wherever there are problems with opioid use, which is really across the country.
I'll close with a word that hasn't been mentioned yet, and that is stigma. And I'll say that ultimately, who gets access to treatment and how we think about those with this disease often has more to do with this than this. And I think until we start seeing the humanity in the person who has this addiction, we're not going to see the changes that we need. And so I think we have to work on ourselves to really appreciate and respect that person as well.
Internal reflection. Yeah.
And I would say you can see addiction every day, everywhere. You pick up a newspaper, you turn on the TV, but what you don't see as readily is that there's 20 million Americans living in recovery. And if we would start spending half the time that we spend talking about the issue and start talking about solutions that's worked in the recovery community, then we would start seeing the needle move. We need to focus more on the successes and not as much on the failure.
That's, I think, the perfect way to end that panel. Please join me in thanking this incredible panel. All right, we're going to take some audience Q&A now. So does anyone have any questions? It looks like we have someone. If you can stand.
Good morning. My name is Andrew Kessler. I work on SUD policy here in Washington. One of the key words I think in this discussion that I only heard twice is trauma. Over 50% of all people with a substance use disorder have some form of trauma in their life, and studies have shown that we need to address this trauma. Can you talk a little bit more about your perspective on treating trauma, especially in youth and adverse childhood experiences, and how that itself is a form of both treatment and prevention at the same time?
Well, our prevention program, which Margaret's a part of, does go upstream and focus on adverse childhood experiences and trauma. So I think Margaret would be great to be able to answer this.
Yeah, I think what I would first say loudly to what you said is we agree that if we can reduce trauma and its consequences in young people, that is one key way to reduce the likelihood that there will be addiction in that young person's future. How do we get there? Well, we're so fortunate to have our funding from the FORE Foundation to be working, for example, with parents and caregivers in recovery. So we're providing some of those recovery support services that can be such an important part of keeping recovery active. And we do that by helping them with their parenting. We know that parenting can be both a great source of joy, but also stressful. And when addiction has been part of your history, there can be some additional challenges. So when we support those caregivers and see them, not only see themselves as effective parents, but also see the way that they respond to their little ones and also their little ones respond to them, we see the benefits of an approach that's focusing on reducing trauma and make sure it doesn't extend from one generation to the next. So just circling back to your question, we agree with the need to address trauma as a major way to reduce paths to addiction.
I love that. I love that question so much. Thank you for asking. I had a patient that I saw recently, actually reminded me, Jason reminded me, one of the things that I love to do when I find patients in recovery is ask them, how did you recover? Tell me your story. And I had this woman who came into the emergency department and came in for abdominal pain not related to her previous opiate addiction. And I asked her, how did you sort of navigate this part of your life? And she said, well, doc, my mother had addiction. And I grew up watching her take pain pills and drink alcohol. And it was just inevitable that I was going to do the same. And she said I had these turbulent years where I would bounce between being high and being in withdrawal, and And she said, it wasn't until I got pregnant and the doctors put me on buprenorphine that I stabilized and I finally got a chance to look back at how I was raised and how I was just going to live the same exact life that my mom, right, was living before me. And then if I didn't break this cycle, my little daughter was going to end up just like me. And so the answer to your question, I think, is that we need to get folks stable, right? Whatever that means for them, so that they can do the inner work to begin to unpack what happened to them, for, you know, that sort of sheds light on why they needed to use medications and use drugs in the first place. What were they trying to heal or, you know, anesthetize in the first place?
Would you like that?
Yes, so I would say, I want to tie this in with the conversation like with the telehealth. So the trauma is the underlying cause of the addiction. And I think as we're thinking about policy, getting them stabilized, absolutely. But when we think about long-term maintenance and treatment, counseling has to be a center. If you're not, you know, I like to say this thing, if you come out every morning and you walk into a spider's web, you knock that spider's web down, but the next morning, the spider's web's back there until you kill that spider. And so it's the same thing. Until we address the trauma and the underlying causes of the addiction, its reoccurrence is going to be probable. And so I think as we think about the policies, counseling has to be the center. A prescription helps and it keeps people, but we want to move the needle into recovery from addiction.
I think that's the name of our new program, Kill the Spider. It looks like we have a question online from Jeff Laredo. Thanks for your focus on evidence, but half of survey respondents listed interdiction as a key. What evidence do we have that a major focus on interdiction reduces morbidity or mortality? Who wants to take this one?
Yeah. Yeah.
Yes. That's right. I mean, you have an idea.
You can come up to the. You can come up to the podium.
Yeah.
I think what we're seeing, you know, is, oh, sorry. Thank you. I think we're seeing it happen right now. I think this year, you know, we're seeing the reduction in the number of fatalities, and we've seen an increased presence or continuum along that continuum by President Biden in terms of making sure that we do reduce the availability, that we're putting continuing pressure on those countries that are supplying these drugs. And as again, 2 weeks ago when the president announced that that we need to take harsher steps on imposing the de minimis tariffs in that loophole, I think we're seeing those steps beginning to pay off. It's not, you know, I think thanks for your focus on the evidence, but half say interdiction is key. It is key, but so is evidence-based treatment. So is evidence-based prevention. And so again, this is the keys are doing all three things simultaneously really well. And so I think the last thing I'll say is, you know, my faith is very important to me. There's a chapel where my wife and I participate, and I looked at the wall. There's a saying from St. Paul, and I think that it took me a long time, right? I'm conservative Republican. It took me a long time to really understand what I was reading, a couple of years. And it said, this quote by St. Paul that said, "Do not be afraid, I'm with you." That's for the people who are suffering. "I am here to enlighten," that's the education, "and live with a penitent heart." The people who, their only addiction is to greed, the dealers that show up, you know, with the knock on the door and say, "Here's half a dozen pills," those people, that is the war on drugs, right? The traffickers, not the people who are suffering from addiction. And so again, it's doing all three of those lines that I think are key, not just interdiction.
Sure, of course.
Yeah.
You gotta have both come up.
I'm going to step into this. Thanks for asking that, Jeff.
Hey, you might have to come to the podium.
Sorry.
Yeah, no worries.
So I think that we often conflate or look at counter-narcotics transnational criminal organizations with what happens at the border. The border is one small line. The transnational criminal organizations are transnational. That's really what, when we talk about what role that plays, it's about the rule of law, right? So it's not necessarily about just that border, because we know that the people who are crossing the border are not bringing in drugs. We also know that American citizens are actually the ones who are transporting drugs into the United States, mostly in motor vehicles. So I think that the issues kind of get murky, and the survey reflects that. Thanks.
Thank you, Regina. Is there another question in the room?
Hi, Gretchen Weiss with JSI Research and Training Institute. I'm thinking from a policy perspective, my question is from a policy perspective, how do we expand or bring into the conversation of the opioid epidemic polysubstance use? You know, the opioid epidemic is now an understood, very recognizable term and crisis, but it is a larger crisis with overdose mortality and morbidity and just polysubstance use in general.
Can I also?
Yeah, go for it.
So they, Virginia, they recently made a change. So previously, if you got licensed with the state, you were called an OBOT, office-based opioid treatment. And they've now changed that to an OBAT, so an office-based addiction treatment. And so that's really how you have to treat addiction, is from a polysubstance use. We see people for benzos, amphetamines, alcohol, opioids, because usually you cut off one supply, then a person that's addicted, they don't just stop using, they just find what's next readily available. I think it's the same approach. It's just there's gonna, with the amphetamines, we use a lot more counseling. We look for an undiagnosed mental health. And I'll ask the audience a question. What do you treat first if a person has mental health and substance use? Do you treat the mental health first, or do you treat the substance use first? It's a trick question. You have to treat both at the same time, because did the mental health, is it an undiagnosed mental health that led to substance use, or did prolonged substance use cause a mental health problem? And so you really have to address both simultaneously.
And I think with that, we are out of time. So again, please join me in thanking this amazing panelist for today.
Oh, that's great.
And with that, I'm going to introduce Michelle back to the stage, close us out.
Do we step down?
You guys can stay. Thank you all so much. Thank you seriously for this incredible panel. We got word, there's social media buzz, and people are very excited. So you'll just appreciate your time here and for sharing your experiences. And thank you to the former ONDCP and former acting ONDCP directors for shedding light on this conversation and bringing in some of the federal perspective. Thank you to everyone in the room and to those of you who've tuned in online. This will be recorded, so you can go ahead and watch it again if you'd like. And our survey results, like I said earlier, are posted on BPC's website, bipartisanpolicy.org. And with that, we will conclude our program. Thank you.